So without further ado, welcome everyone to the DrDoctor headquarters here in Waterloo in London. I won't keep it much longer. I'm going to hand over to Tom Witcher, our first speaker who's doing the talk live. Tom is CEO of DrDoctor and one of the founders who actually founded the company back in 2012 with his co-founders Ranesh Amin and Perrin Pingley. Tom is an engineer by background and is very passionate about digital transformation in the NHS. Obviously, that's what we're talking about here today. Tom is also an NHS NIA Innovation Fellow. And I'm going to hand over to Tom now. Thank you very much.
Thanks, Netta. Nice to meet you, everybody, and thanks for hanging on. We've got 3 really engaging sessions for you today. After me, we've got Kelly Rank from Central London Community Hospitals and David Wallaker from Oxford University Hospitals to talk about patient engagement on the ground in their trusts. Before we do that, I want to talk to you about patient engagement and why we think it matters. As you can see, anybody who's seen me present will recognise this slide. This is a photograph from Italy, from Vatican City in 2007. And as you can see, in the bottom right-hand corner, there's one mobile phone, a Motorola Razr V3, if anybody remembers those. If we fast forward 7 years to 2013, this is the same place, pretty much the same people, it's the same setup. Everybody's holding up iPhones and iPads. If you've been to a gig recently, you realise how annoying that is. Mobile phones have fundamentally changed the world. And if you roll back a year, they hadn't really changed healthcare. But what's different today is the world looks like this. COVID's changed the way that we think about everything. And where patient engagement was important before, it's now fundamentally necessary to the way that we change healthcare systems. Because we're facing a huge backlog, and the patient backlog isn't a new problem. It's a problem that's actually been growing across Western healthcare systems for a long time because supply and demand have been really out of sync. This chart here shows some data that we've got from our hospitals. So as you can see, the backlog was growing ever so slowly until COVID hit in the end of February. The number of attended appointments in the NHS goes down significantly. The number of DNA appointments in the NHS goes up significantly. And the purple dotted line shows that the delta between those two is the increase in waiting lists. That's happening because we don't have capacity to scale in the system. The amazing thing about patient engagement done right is it's an opportunity to fundamentally solve that problem, to think differently about how we deliver services, and at the same time improve the patient experience. So it's one of the few things that we can do that helps us solve this kind of structural problem we have in healthcare in the Western world. It helps us deal with the immediate impact of COVID and actually improves the patient experience as well. So we're going to and the key thing is that without some different way of working, the recovery will take years. So even if we ramp up capacity now, because the waiting space is so massive, we estimate it takes 5 to 6 years to catch up to where we were before. So it's time to think about doing things fundamentally differently. And the really exciting thing is that the evidence from the audits we've done and the evidence we have from working with people on the ground is that up to 60% of follow-up appointments are not needed. So there is a real opportunity to take advantage of the reset, think about how we're managing services, think differently, and actually, rather than kind of brute force our way through the backlog just through doing more extra activity, think about the problem differently from the start. And I'm going to talk briefly about some real-life examples of patient-initiated follow-up, see on need and see on symptom type pathways, and how by putting those into practice, we can make a massive difference to this backlog. But before we do that, we have to step back a moment because this all starts with engagement. And we know that if we don't get the patient engagement part right, i.e. we don't get the foundation of our digital patient journey right, none of the PIFU stuff works. None of the follow-up management stuff works because patients need to be onboarded correctly. So when we think about this at DrDoctor, we think about a 3-step process. Step 1 is about engagement and shift to digital. This is about laying a solid digital foundation for patients in your trust. I know that David and Kelly are going to talk about this. It's things like DNA reminder messages, it's things like digital letters, it's things like strong patient portals across a range of different platforms. By getting these things right, what you do is you lay a foundation of engaged patients at scale with whom you can then take the next steps in a digital journey. So, for example, when we go live in a trust, we normally target sort of 60 to 70% of patients going digital. That might mean letters, it might mean text message notifications, it might mean use of a patient portal. Get that base right first. The next step is about automating back office processes. So you've got a large number of engaged patients using your platform, and you begin to ask them to do some of the admin themselves. So, for example, getting patients to book their own follow-up appointments is a really important step in reducing DNA rates and maximising clinic utilisation. We know that clinics that are partially booked tend to have a sort of a 3 to 4% DNA rate as opposed to a 7 to 8% DNA rate in fully booked clinics. And we know that the clinic utilisation in those clinics where patients book their own appointments is higher too. There's a knock-on positive effect, of course, as well, which is that we save administrative costs because the patients are doing the booking themselves. And the last benefit is it reduces churn in the system, because about 30% of appointments which are booked tend to get rescheduled. They get DNA, they get cancelled, they get rescheduled by the hospital. We know that if patients book their own appointment, we can reduce that by about half. The other thing that the automation layer allows you to do is it allows you to start collecting data from patients. And once we start collecting data from patients, for example, PROMs and outcome data, we can then think about the last part of the transformation journey. And that's follow-up management, it's triage, it's pre and post-clinic assessments, using the data that we collect from patients to start to run more intelligent stratified pathways, begin to reduce the follow-up load in our hospitals and start to see people based on need and not time. I'm going to drill into a couple of those today as an example of how you can use data-driven PFU to reduce follow-up load in hospitals. All of this, of course, is underpinned by a really important thing, which is interoperability, data analytics, and AI. And I'm really pleased to say that DrDoctor was picked as one of the 4 high-impact innovations by Accelerated Access Collaborative this year. We've got the funding to roll out our DNA prediction models, our follow-up management clinical triage models, and our linked appointment matching logic across all of our clients. That's really important because those pieces of the puzzle come together to build a holistic platform that can do all of this. So how do we practically tackle the backlog using something like data-driven PFU? I've got 2 examples of pathways. So the first example here we have is what we call a patient-initiated see-on symptoms pathway. There's 4 slices here. So the first step is to manage your waiting list and triage the backlog. Use simple forms to send patients a question like, do you still need this appointment? Are you COVID symptomatic? A bunch of other clinically led triage questions. Clinicians can then triage that backlog into 3 types of risk: high, medium, and low. Low patients can be discharged or don't need a follow-up appointment at all. High-risk patients go immediately onto a clinic list to be booked in and seen face-to-face. And then it's in the medium-risk patients where there's opportunity to make service improvements. I'm going to talk about one specific example here, which is a see-on symptoms patient-initiated follow-up list. So what this process flow shows is an example of a patient being booked into a see-on symptoms pathway. So a see-on symptoms pathway is where we've triaged that patient into a medium risk group. They're probably somebody we know well. They've got a good relationship with their consultant, and they're probably managing their disease okay. So they might be a patient with diabetes or rheumatology or a gastro patient that's got a fairly good handle on what's going on. And what we say to them is, we trust you to self-manage. But if you have any of the following symptoms, please go online and fill out one of our quick triage forms. Based on what the patient puts into that triage form, they then go through a number of different steps. And you can see on this slide here, they might use text message or they might use the patient portal to do this. But they go to some async advice and guidance. And if they are symptomatic, they then get the opportunity to book themselves in using the PFU direct booking tool. So let's say I'm a diabetes patient. I'm fairly good control of my blood sugars, but I'm starting to get some symptoms. I book myself in and I get seen on a see-in symptoms pathway. That means I get seen much sooner than if I waited for my regular 6-month appointment, but I only get seen if I'm symptomatic. As a clinician, what this means is you see the high-value patients first, and you don't spend your time in clinic working through a backlog of patients who are fine or have been seen recently by a GP or don't need your help. So we prioritise the sick patients, and that allows us to reduce the net amount of demand on the system while seeing people who need it first, which improves outcome. It's a double win. The next example I've got here is a see-on need example. So this is a slightly higher risk patient. So this is somebody who perhaps isn't quite as in control of their care, or perhaps is a bit more acute. So for example, the video I'm going to end with is from Nottingham University Hospitals, where we rolled this out across oncology services. And in oncology, we saw a 40 to 60% reduction in face-to-face appointments across a range of different specialties, including breast cancer, prostate, and immunotherapy. The difference here is we're actively monitoring this patient's care. So rather than them coming to us when they're symptomatic, what we do is we send them a form on a regular basis. It might be daily, it might be weekly, it might be monthly, but that time is set by a clinician. They get sent a clinically validated questionnaire and fill it out. It comes back to our system where it's reviewed by a clinician in a digital review clinic. In that digital review clinic, they have all of the patient biomarkers, the data that's collected by us, and a set of other data that might come from PANS or EPR. The clinician makes a triage decision. Am I going to see this patient now? Am I going to send them an asynchronous message to tell them to keep doing what they're doing, or do we not need to see them at all? If their journey through care isn't going well, they get brought back sooner. Or if they just need a small interaction, they're going to get a quick async text message or push notification that says, "You're doing well. We're just going to address your drug dose," for example. This, and at any time, the patient also has a choice of booking themselves in. This active monitoring allows us to control risks through the pathway much more strongly than the See on Symptoms pathway, but still keep patients out of hospital. It's a really powerful way to start rethinking how we manage specialties that have got lots of outpatient follow-ups. It's really good for clinicians, and it's great for patients. That's all I'm going to say today. What I want to finish with is a video from Nottingham where we've talked to some patients and we talk about what the experience of going through one of these pathways is like and how much better it is. Thank you.
Follow-ups. If I can, just for urology, I do demand capacity modelling consistently every single week, and at the moment we are following patients up annually, biannually, when they don't necessarily need to be seen. You could be seen in clinic today and the consultants will see you in 2 or 3 years' time. If we could manage that differently, these patients wouldn't need to come back. We could manage it virtually, and they'd only have to come in if they needed to, if they were symptomatic. At the moment, we're following up whether they are or not.
The follow-up management product is all about taking patients' care and changing it from being time-based to need-based.
Patients are invited to complete a form via text message or email. They complete their form online on their tablet or mobile. Once completed, the clinician is informed and reviews their form, and off the back of that makes a decision whether a follow-up appointment is needed or not. They then directly message the patient about their assessment and the outcome, keeping the patient in the loop of whatever is going to happen.
I think remote monitoring, particularly using something like the DrDoctor platform, will enable us to have fewer patients coming to clinics, which then frees up our own time to see more patients in a more flexible manner. To the other side of the spectrum, those with severe symptoms are seen much quicker, so that if they need to have surgery, then that can happen in a very timely fashion.
For me, the attraction is to be able to signpost our breast patients to either a physical face-to-face appointment or psychological support from their breast care nurses, or no appointment at all, which has advantages in that they're not having to take time off work, they're not finding it difficult to park, they're not becoming anxious when they return to the breast unit where they were diagnosed with their breast cancer.
Clinicians, they don't necessarily just want to do something because it saves money or it saves hospital time. They are aware of that, but actually a key driver is patient care. And actually if they can still give patients a better experience and a better journey, then they're all for that.
My name is Sibby. I'm the mother of 2 daughters, and I was diagnosed with breast cancer last October. So to come for a radiotherapy session here, it takes half a day. It takes half a day out your timetable. And most people, whether you're travelling public transport or driving, the challenge driving is finding a parking space, getting stressed, being late, the traffic's awful. One of the things about cancer is that loss of control. So it's happening to you, and a lot of people find that very difficult to deal with. And so just getting some semblance of control back is really important.
I think as we see an increase in the demand for healthcare and ageing population, we'll see that actually the provision of effective follow-up care and the management of it will become increasingly important. The demand for it is going to be enormous across our population and other populations.
What's really exciting about the follow-up management product is we're beginning to build what I think is the future of healthcare. Across the globe and in the NHS, we're beginning to recognise that there is a fundamental challenge with supply and demand. And what the follow-up management products allow us to do is it allows us to fundamentally change that equation.
Go to other specialties that have done it, go to other health boards who have done it. Come and speak to us. We'll show you how well it works.